Hopping on in. I'm just gonna wait a few more minutes, and I see the ticker tab still climbing slowly before we get rolling. Thanks to the journal and to Dr. Humphreys for involving the young surgeon section. Indrani, I'm one of the members hosting this month's session. If any of you who are watching would like to host in the future, please reach out to Dr. Humphreys or to me and we'll make it happen. We have two amazing papers today. The first is the paper on evaluating the management of intermittent claudication before and after publication of the Journal of Vascular Surgery's appropriateness of use criteria. And the second is the textbook outcomes after revascularization for chronic limb-threatening ischemia are rare. We are very glad to welcome our presenters, Dr. Sujko, Dr. Chitwood, Dr. Picha, and Dr. Kanzafarova. And it is always awesome when our author guests are here with us too for both the papers, Dr. Alonso and Dr. Syracuse, and Dr. Kosa and Dr. Chung. I hope there is a lively discussion, as there usually is at the end of this. We welcome our special guests, our moderators, Dr. Rossi and Dr. Pham. And before we get going, just a few housekeeping announcements. Please do stay muted and submit a lot of questions in the chat. These are both wonderful papers. You can ask as many questions as you like. The event is being recorded for on-demand access. And the next online journal club will be on September 10th, and the rest of the dates for 2025 are posted on our on the site. So without further delay, I'll stop share here, and I'll invite the first set of authors to go ahead with presentation of the appropriateness of use guidelines. Over to you, Dr. Chitwood.
Good evening, everyone. Thank you, Dr. Sen and Dr. Humphreys and the JVS for letting us, and the SVS for having us be invited to present this paper and be involved with tonight's discussion. We're pretty excited about it. So just by a little bit of background on the first paper that we're discussing, it has to do with pre and post kind of implementation, or when this appropriate use criteria for management of intermittent claudication came about from the SVS. And so I just wanted to go over a little bit of the background of that process, and then I'll have Dr. Chitwood, one of our third-year residents that's in our his research time, take over. So for this document, they use the RAND appropriateness method, which is a validated and standardized method that combines really the best available evidence with expert opinion using a modified Delphi process. It really is to serve as a framework for the clinician and the patient, and it's not really set to be very strict on, what you should and shouldn't do, because we all know that we have different cases and different patients with various factors that are going to influence the management. And the AUC really was generated from a panel of providers of all backgrounds, so some vascular surgeons, some interventional radiologists, interventional cardiologists, of going through multiple really impressive, greater than 2,200 scenarios that they went through and rated on 2 rounds, 1 to 9, to really get a consensus from those experts and the available research to figure out what was the basically the recommendation on certain scenarios. This was also based on open and endo. It was also based on anatomic location. And really the rating system here, it just kind of lays out that number 1 would be, where the risks clearly exceed the benefit, versus 9, where the benefits clearly exceeds the risk. So with that, I'll let Dr. Chitwood take over for more of the summary of what this document found, and also the paper we're discussing tonight.
Can you see that? Do you see presenter? Let me go back to the beginning here. Sorry.
It's in presenter mode right now, Joe.
Let me fix that. try this. All right, can you see this now?
Yep, you're
Yeah.
all set.
And can you hear me? All
Yes.
righty. Well, hello everyone. Thanks for joining us tonight. First off, I wanted to thank the JVS team for allowing us to co-host this journal club with the University of Rochester, and I'd like to thank my faculty here at UAB for selecting me to present this article. As Dr. Setsko said, my name is Joe Chitwood. I'm a PGY3 here in the Integrated Vascular Surgery program at UAB, and I'm in my academic development time on research. Tonight, I'll be presenting the Editor's Choice article for August 2025 issue of the Journal of Vascular Surgery, titled Evaluating the Management of Intermittent Claudication Before and After Publication of the SVS Appropriate Use Criteria. Now, I know whenever a new set of guidelines are released, some may be resistant to change, some may be slow to adopt, some may be weary of the guidance or unaware overall of its existence. Or some might be like me, just trying to keep up with everything that is being published. But tonight I tried to come up with a summary for you all and do a brief overview of the SVS intermittent claudication appropriate use criteria for those who are not already familiar, and as a refresher for those who are, in order to better understand the article. There are 5 criteria laid out in the AUC, and it was published in April of 2022. And summarized here, number 1, exercise therapy is the preferred first-line treatment for all patients with claudication. Number 2, for patients who have not or cannot complete exercise therapy, invasive treatment may offer net benefit if they are non-smokers, are on optimal medical therapy, have low physiologic or technical risk for intervention, or they experience lifestyle-limiting claudication. Number 3, for lesions in the femoral popliteal segments, invasive intervention should be reserved for patients with severe lifestyle-limiting symptoms or short walking distance. Number 4, in patients with claudications and lesions in the common femoral artery, open femoral endarterectomy provides greater benefit than endovascular interventions. And lastly, interventions in the infrapopliteal segment provide unclear benefit and may portend greater harm to patients with claudication. For objective and study design, the objective was to evaluate practice change associated with the release of the SVS AUC for intermittent claudication among vascular surgeons and interventionalists, utilizing the Vascular Quality Initiative database. This is a retrospective cohort study of the peripheral vascular intervention, as well as suprainguinal and infrainguinal VQI registries. The inclusion criteria is age over 18, and then patients who underwent primary intervention for intermittent claudication. Some exclusion criteria were interventions for chronic limb-threatening ischemia, acute limb ischemia, and aneurysmal disease, as well as patients who had undergone prior revascularization, whether it be open, endo, or amputation, as well as internal iliac lesions. The authors identified a pre-AUC cohort of patients who underwent interventions prior to the publishing of the SVS IC AUC guidelines. This time frame spanned from January 2018 through April of 2022. Notably, patients who underwent intervention from January of 2020 through December of 2021 were excluded due to disruptions in care from the COVID-19 pandemic. The post-AUC cohort consisted of patients who underwent intervention following the release of the AUC, and the time period of study was May 2022 through December 2023. Between the 3 different VQI registries, the authors compared multiple demographic, disease-specific, and operative variables to detect any significant practice changes among VQI providers before and after publishing of the AUC guidelines. Some variables that were included were age greater than 80, severity of disease, which ranged from mild to moderate to severe. Notably, this variable was not tracked in the bypass registry, so was not able for analysis in those registries. Some high-risk comorbidities included were heart failure, coronary artery disease, COPD, diabetes, obesity, dialysis dependence, renal transplant, and CKD with creatinine greater than 1.8. Optimal medical therapy, both pre and post-op, were variables. Frailty, which was determined by an MIF-5 scoring system, which uses functional status, the presence of hypertension, heart failure, COPD, and diabetes, each assigned a point for which a score greater than 2 indicated frailty. Anatomic level of disease, which was defined as aortoiliac, common femoral, femoral popliteal, and infrapopliteal. And disease severity based on task 2 criteria, with an emphasis on task C and D lesions, which were deemed complex in the aortoiliac and femoral popliteal segments. Bypass type included suprainguinal extra anatomic bypass, with a focus on axillary versus femoral proximal anastomosis, and then the femoral popliteal and infrapopliteal bypasses categorized by the distal arterial target. And then lastly, bypass conduit, which was GSV versus others, such as prosthetic. Here are some results tables from the article. The tables compare the differences in the pre-AUC group versus the post-AUC group in the 3 different registries. Table 1 is the peripheral vascular intervention registry. Table 2 is the suprainguinal, and Table 3 is the infrainguinal bypass registry. Focusing on Table 1, there were some significant changes in practice deemed positive or aligning with the AUC. These included a significant increase in patients undergoing PVI for severe intermittent claudication symptoms, a decrease in patients with history of transplant or dialysis dependence undergoing intervention, increased post-op optimal medical therapy use, and decreased number of patients with complex task C or D, aortoiliac and femoral popliteal lesions undergoing peripheral vascular intervention. Conversely, there were also significant change in some areas which did not align with the AUC. These included a greater number of patients with heart failure undergoing intervention, more endovascular interventions in the common femoral and infrapopliteal segments. Notably, there was no significant change from previous practice in the VQI suprainguinal as well as infrainguinal bypass registries post AUC publication. This slide summarizes the previous slide regarding practice changes seen post-AUC. I wanted to highlight here that in the bypass registries, no significant change was seen in active smoking status, pre or post-op, optimal medical therapy. Patients with high-risk comorbidities undergoing surgery remain similar to previous levels. Use of extra anatomic revascularization was similar, and frequency of femoral and popliteal and infrapopliteal bypass, as well as conduit choice, did not see any significant change. For the discussion, the authors noted concern for overuse of infrainguinal endovascular interventions. They postulated that the reason for ongoing and increased use may be due to wider availability of endovascular devices, a rise in OBLs and OSCs, market competition among providers, as well as Medicare reimbursement. The shift to intervening on more CLTI and lifestyle-limiting claudication patients may be due to awareness of the AUC and potentially ongoing aging population, as well as delays in treatment where patients were receiving care at a more advanced disease state. The lack of practice change in the supra and infrainguinal bypass may be influenced in many circumstances by indeterminate ratings in the AUC for bypass based on the current body of evidence and some complex situations that are faced in those discussions and those decision-making processes, as well as a potential shift towards more conservative therapy and medical management in these patients with complex aortoiliac and infrainguinal disease. In regards to opportunities for improvement, the authors identified subpar OMT compliance rates and risk factor modification in regards to smoking cessation perioperatively as areas of concern. Additionally, risk assessment with ongoing shared decision-making conversations regarding risks and benefits, mortality, risk of cardiac and limb events postoperatively, functional outcomes, and health-related quality of life should guide the decision-making process to preserve intervention based on the highest level of evidence. Lastly, ongoing dissemination of the AUC will continue to inform providers with the goal of continuing to evolve practice changes moving forward. Included here are also some of the limitations, which are primarily due to the nature of the study and limitations of the VQI registries as a whole. And since we were on the topic of guidelines, I wanted to make an Office Dwight reference, which I felt was fitting. So learn your rules, folks. And here are my references. And then I'll open the floor to further discussion.
Thank you, Dr. Chitwood and Dr. Cisco for that excellent presentation. I wanted to open up the discussion with a question that was actually submitted by a student rotating on my rotation. His name is Nolan Bashore. He had an excellent insight, and I wanted to ask the authors. So they noted that the post-AUC study timeframe was between May 2022 and December 2023. So this is a total of 19 months after the appropriate use criteria was published. So do the authors feel that this is a long enough period to really see a change in practice? As we know, medical knowledge takes time to disseminate, and once it is disseminated, it takes time to implement. Therefore, do they feel that this is the long enough time to see a real change? And do the authors plan to have some follow-up studies for longer term results to see if the practice patterns are going to start aligning more with the appropriate use criteria?
Thank you, Dr. Pham. That's a really good question. The goal of this study was really to look at the immediate impact of the publication of the AUC, given that it was published at a rather timely when there's been a steep rise in particularly endovascular interventions for claudication. It's there. That's always the question, whether there was long enough time period for dissemination of the guidelines. And so a potential future study could look at this at a longer time period, maybe do like an interrupted time series or something. But interestingly, when we did a sub-analysis for the study, we broke up the 19-month period between May 2022 to so basically all of 2022 and then all of 2023, and the steep changes in practice actually occurred in the first half of the 19-month period as compared to the second. So that was a really interesting observation for us. Perhaps, I mean, this is as a retrospective cohort, as a cohort study, it's hard to pinpoint exactly what caused the changes, but it was very interesting to note that all these big changes that we observed really happened in the first half of the 19-month period.
Yeah, I think there's two ways to look at things changing. Sometimes it may take a while, but also sometimes maybe people pay more attention when it comes out, and it's already old news now 3 years later. So I think it'll be interesting to see kind of long term what happens with that.
Thank you for that response, Dr. Alonso. Dr. Humphreys asked the authors, do you think that the AUC guidelines have been appropriately focused on the SVS? Meaning, have we done a really good job as a society trying to disseminate these guidelines, or is there more work to be done to really get it out there so people can actually are aware of it?
Yeah, I can handle this one. I think the SVS is still trying to figure out what they're gonna do with the AUC guidelines. There was some last minute changes here. Originally it was appropriate, inappropriate words in there, and we were encouraged to take that original AUC to make it risk benefit ratio. And so we haven't had another AUC since then, which I think there is a plan for an upcoming one. So I think, you look at the ACR, they do about 5 or 6 of these a year to a lesser extent. So I think it's still new to the SVS. And I think they're still trying to figure out how they're going to navigate it. But they were very supportive for the most part in the process and really helped fund this.
Well, we do look forward to more AUC coming out, because we don't want the radiologists beating us, obviously.
Exactly, because all the other societies, the radiology and the cardiology societies, actually did a PAD one several years ago that we didn't sign up for. So if we don't do it, it's going to happen for us. So
to follow up on that question, Dr. Syracuse, so there was an increase in endovascular intervention performed in the common femoral and the isolated infrapopliteal after the appropriate use criteria. Do they have a way of knowing which specialty is driving this increase? Because as you mentioned, other societies may not follow our same appropriate use criteria, or as you mentioned, they have their own separate set of criteria to follow. And so is it one specialty versus another that's driving this? Or because I like to think that as vascular surgeons, we are acutely aware of the AUC, and I like to think that we're the ones playing by the rule and we're the ones behaving. and the other specialists are not behaving. So is there a way to differentiate to see which one is driving these increases?
Yeah, I don't know that's always the case, and to kind of answer Ahmed's question too. I don't know even that among VQI authors, because even medical management is always subpar in the VQI analyses for a lot of the PAD. The VQI has never and probably will never release specialty data about generally. In New England, it's a little more vascular surgeons than the rest of the country, probably about 60-70% in New England, but less so, more 50-60% for the rest of the country in the VQI are vascular surgeons. So there is a significant amount of people in the VQI that are not vascular surgeons, but that data has never been released, and I don't know ever will, because it would obviously discourage participation, the thought is.
Question from the audience, do the authors feel like there's a bias here? Because the VQI data, the VQI centers are probably more likely to be aligned with the AUC guidelines at baseline rather than the non-participating VQI centers.
Yes, it's
Andrea, you want to take
possible. Yeah, it's definitely a limitation of the study. We're limited by the type of centers that participate in the VQI, and so that definitely could be a bias. It's possible that the rates of interventions are higher outside of the VQI.
To follow up on that question, another question from the audience, was there a way to differentiate where these increases in the non-alignment of the AUC were they happening in the OBLs, were they happening in the acute care surgery centers, or were they occurring in the inpatient setting?
Well, we didn't look at that, but it's a good question.
Yeah, only about outpatient ambulatory is about 10-15% in the VQI. So it's kind of, they're on the lower end of the numbers, and a lot of those may even be affiliated with the hospital. It's hard to know who owns what in the VQI.
Another question from the audience: should we define ongoing tobacco use as a clear violation of AUC guidelines for all levels of disease? And how do we make improvements here? Because this, I struggle with this in my practice as well. Patients, students would come on my rotation and ask me how much of my patients actually quit tobacco after I counsel them. And I say, about 10. I was like, 10% is like pretty good. It's like, no, I've convinced 10 patients in my 8 years of practice to quit tobacco use. So it's a very meaningful question. Do you feel like this is something that can be done or should be done, meaning tobacco use as an ongoing violation of AUC guidelines?
Yeah, I mean, there was in the original AUC, it was split up a lot of categories: nicotine use, current user, non-user, and it did affect the recommendations to an extent, but not as much as I think you would think it would. Personally, I'm very concerned about treating claudicants, especially if they smoke. But I'm a little bit on one extreme end of the spectrum, I think, on that. And I think you get a lot of different opinions here. Some people say, well, you're punishing patients who are still smoking, have a hard time quitting, where the other end is may not be doing them a favor that you think you are by treating them, because you may go down, you may make them worse. So I think I'm biased. Obviously, I try and avoid treating people actively using nicotine, but I think you can get a lot of different discussions even on this with this panel on this.
Yeah, I appreciate your approach on that. But if I were to say to decline interventions on my patients who smoke, I would not be doing any surgeries at all. So that's unfortunately is rampant. I'm sure it's rampant everywhere. That for the audience, I'm sure it's rampant everywhere as well. On table 1, the authors noted that the common femoral artery endovascular intervention did not change before or after the appropriate use criteria. So was there a way to determine if this was an isolated or could have been a part of a combined intervention? And is there a way to discern this in VQI? So for example, if I'm doing a superficial artery intervention and I need to get my device down to the SFA, sometimes I've had to use a atherectomy to clear up the common femoral artery in order to get my device down to the SFA. So when they were looking at this in the VQI, was it associated with just the isolated common femoral, or was it associated with another intervention in addition to that?
These were isolated common femoral interventions.
So there was a way to define that in the VQI?
Yeah, in the endo group only.
Okay.
In the endo group, only.
common femoral interventions are not recorded in either open or endo with open registries.
Another question from the audience. How should we publicize the guidelines in the primary care and other specialties? Do they understate the harm that some procedures can have for patients with claudication? Because a lot of my patients, when they are sent from their primary care physician, they get afraid because they see vascular surgery. They automatically assume that they're going to require surgery. So what can we do as a society in terms of publicizing this to the primary care physician so that they don't automatically think, oh, I have intermittent claudication, I'm automatically going to have to undergo some type of intervention?
I think it would be more than publishing the guidelines, maybe important parts of the guidelines. So really getting out to the community, the importance of exercise therapy for patients with claudication, optimal medical therapy, smoking cessation. I think it seems like a lot of patients with, claudication or lower ABIs are immediately sent to a vascular specialist, when perhaps this could be, for mild, moderate disease could be dealt with in the outpatient setting. To date, it looks like exercise therapy is still relatively underused.
I agree with that sentiment. The exercise therapy, most patients just don't do it, and patient compliance is such a challenge. And in a lot of small areas like myself, we don't have the structured exercise therapy program. And so I just end up telling the patients to go home, walk 30 minutes a day, 3 days a week, walk into the pain, and then pass the pain to develop the collaterals. And I've had about a handful of patients that are actually doing that. And amazingly, the handful of patients who do that tell me that they have increased walking endurance, not surprisingly, but it's still a challenge to get that out. Question from the audience. So how do we enforce the AUC? Is there a role for regulatory changes or payment changes? They noted it's a loaded question, but is there a way to enforce this and not just make it a voluntary kind of thing, or is there a role to make it a regulatory process rather than a voluntary process?
Well, I think we always worry about once we do that, then things will be more, we might not like what we get when we open that up. So we got to be careful with that. But at the same time, we already have delays of 3 months for compression a lot of times to get a venous ablation. So there does exist something for that. So, there probably is a role of that, but, I always worry about having outside regulations of the physicians. But, you may say, hey, you got to do at least non-supervised exercise therapy, try smoking cessation, have better glycemic control, try to fix your A1C for 3 to 6 months. I mean, that may happen at some point, but I think we got to be smart about how we do it.
And I'm hopeful that, with the publication of AUC, we will police ourselves, because again, if we don't police ourselves, somebody else is going to police us. And I'm sure we are all very aware of all the regulatory hurdles that we have to face nowadays. So another regulatory hurdle is probably not going to be welcomed. One last question from the audience. So we're required, and in venous disease, we're required to have patient wear compression prior to treatment. Do you think, CMS should enforce exercise therapy before treatment is offered on these patients with intermittent claudication?
I think that would be a good route. I think, if I remember correctly, after the CMS expansion, they now cover for exercise therapy, but I'm not sure if that is only covering like inpatient in hospital therapy. I don't know if does it expand to like if you do home exercise therapy, just making it more feasible for patients, especially those with poorer access to care.
All right. One of the Dr. Sen noted that she has seen some changes from insurance in her practice, asking for a 12-week supervised exercise program. And so she is mentioning that she uses that to her advantage and asks patients to do that before they are offered any type of intervention. Okay. So for the trainees out there, ask them to go ahead and do that, and then that way you can encourage them to do that, and that way you can align with the AUC guidelines as well. So another comment from the audience. So the papers noted that these changes raise concern for overuse, with prior reports suggesting other possible factors influencing practice, such as access to endovascular devices, the rise of hospital-based labs, and ambulatory surgery centers. So they mentioned that the audience member mentioned that using the VQI data to make conclusions about outpatient practices that aren't reported in the VQI can lead to conclusions that aren't necessarily correct. Is there a fear that, when we make these, when we publish these type of papers, that other regulatory bodies are looking at this and can be using this against us?
Yeah, I think that's what I alluded to before, but at the same time, there's countless papers with Medicare and everything out there on that look at the topic more specifically, more granular than this. So it's not really, this isn't really a surprise. And non-hospital ambulatory center is a variable in the VQI, though it's about 10-15% the PVI.
Well, thank you for that excellent discussion. I think those are all the questions that are from the audience that I can see that are relevant. Any other comments out there? Any other questions from the audience?
And that is perfect timing too. So we are right on time. Thank you for that. And Dr. Kanzfarova, if you would like to get us started with the second paper now.
And John, you wanted me to introduce it?
Yes.
I guess.
Yes, Grayson. Thank you.
All right, I'm rolling. Thanks, Misty and Joe, first off, and Indrani for having me back. I don't know why you guys continue to invite me. This is, we'll see. But this is textbook outcomes after revascularization for chronic limb-threatening ischemia. I really like this article a lot. Number one, I'm a big fan of Jair Chung. There's no doubt about that. Phenomenal writer. And two, although not explicitly meant, it gets into things that I really enjoy about PAD, and those are the challenges. What matters most to our patients and our practice are outcomes. But how we get from point A, the diagnosis, to point B, the conclusion or outcome, is this wide spectrum that does not look like the golden brick road in this picture. And traditionally, we've defined outcomes for chronic limb-threatening ischemia as the following. And these are all pretty good outcomes, right? These are all things we want. Amputation-free survival, sure, that's great. Patency, yeah, absolutely. Limb salvage, mortality. Yeah, when we're planning revascularizations, there are things we really want and our patients really want. And we all have excellent plans. I can plan better than anyone, but the journey to that outcome may not be representative of the most desirable journey or outcome for that patient. Take, for example, when my wife is on call and I'm in charge of the children. Now, as you can imagine, I have the best ideas. I always have the best ideas and best plans, period, for the kids. So just like the good doctor that I am, I'm also the fun parent. And my children love Daniel Tiger. And so one weekend they were watching this episode and they see Prince Wednesday and Daniel Tiger get into a sweater involved. Oh, skipped ahead a little bit. And I think, wow, this is awesome. I bet if I get a picture of my kids like that and the outcome will be the picture, my wife will love it, they'll love it, everybody will be happy. And certainly it was a perfect plan with a perfect outcome. My kids absolutely loved it, right? There was nothing better than that. And that's kind of the point of this. Things happen, or things may or may not happen. And outcome metrics often fail to capture the true procedural burden associated with revascularization. We often don't capture the in-between. The time of wound healing, the burden of appointments for patients and their families coming back to clinic each week or twice a week for wound checks for months on end, the support needed to get those patients to the clinic and the repeat interventions and debridement and the revisions, and it goes on and on and on and on. I know all you guys have seen, I know Misty has seen the same patient for weeks on end. And you may have a patient with an amputation-free survival, and that's great. But at the end of the day, they're ambulatory. And what is their quality of life? And so this is sort of what Dr. Chung and his colleagues got into, is that all the traditional metrics that we typically use, well, they may overestimate the benefit of revascularization. So in this context, Dr. Chung they coined the term textbook outcomes based on colon cancer and abdominal aortic aneurysm study by Dr. Beck. And textbook outcomes are these composite outcomes that to them represent the most desirable outcome. And textbook outcomes become complex because they're individualistic and patient specific, but they're incredibly meaningful in providing education for real world problems clinical trial education outcomes, and comparative assessments between providers and different hospitals. And as we know, not to spoil the manuscript, but textbook outcomes are pretty rare in vascular surgery, at least for me. And I imagine this paper was the inspiration, which shows that despite graft patency and limb salvage, a significant portion of patients ultimately did not have wound healing. And Jair wrote this, I don't know, when was this? 30 years ago? A long time ago. But with that, I will introduce Dr. Kanza Farova, who's our 4th-year resident at the University of Rochester. And she's phenomenal. You guys should look to hire her. She's great. She's going to present the paper.
All right, everyone. I do really appreciate opportunity to present very interesting article tonight. Textbook outcomes after revascularization for chronic limb-threatening ischemia remain rare. The research group from the Baylor College of Medicine raised the concerns that current performance outcome metrics and traditional surgical benchmarks may be inadequate proxies for evaluating the quality of revascularization in chronic limb-threatening ischemia patients. They proposed a textbook outcomes in CLTI patients to provide a more comprehensive evaluation of modern CLTI outcomes. They performed a 9-year retrospective single-center analysis of consecutive patients with CLTI undergoing revascularization in open endovascular or hybrid approach, and they included patients with CLTI. They included patients with venous wound etiology with symptoms limited to claudication only, acute limb ischemia, ischemia due to embolus or trauma, or patients who had non-atherosclerotic conditions, or someone who was managed without revascularization. They also excluded patients with less than 1 year follow-up, except of those who died or had a major amputation within the first year, which were excluded. So authors defined textbook outcomes as fixed 1-year composite outcome requiring survival, limb salvage, no vascular re-interventions, freedom from major 30-day complications, 1 or less wound-related procedure, return to baseline and on normalized ambulatory status, and complete wound healing. Patients who experienced major amputation or death within the first year were classified as non-textbook outcome group, regardless of follow-up duration. Moreover, the non-text outcome group was subdivided into 3 subgroups. The subgroup number 1 included patients who met all textbook outcome requirements except of having more than 1 reintervention and 30-day major complication. Subgroup 2 included patients who survived with limb salvage at 1 year, but failed to heal their wounds with more than 1 reintervention or failed to return to baseline ambulatory status. And subgroup 3 included patients whose revascularization was followed by mortality and major amputation at 1 year. Reinterventions included vascular and podiatric procedures were included during the 1 year after the initial procedure. And the procedures were categorized as major or minor as depicted on the slide. 702 patients with CLTI or 905 limbs were included in the study. The median follow-up was 25 months. 29% of patients were treated for rest pain only, and distribution of patients in textbook outcome and non-textbook outcome groups based on the Wi-Fi clinical stage is depicted on the slide. In terms of the revascularization performed, 71% of patients underwent endovascular treatment, 23% of patients underwent open procedures, and 6% of patients had hybrid procedures performed. Textbook outcomes were achieved only in a quarter of limbs included in a study. Patients in textbook outcome group were more likely to be male, had higher rates of private insurance, were less likely to live in assisted living facility or being wheelchair bound. In terms of comorbidities, textbook outcome patients had lower rates of diabetes mellitus, chronic kidney disease, end-stage renal disease, and atrial fibrillation. Survival and limb salvage in 1 year was high across the cohort. Complete wound healing and return to baseline or normalized ambulatory status was achieved less frequently across the entire cohort. 1 year freedom from vascular reintervention, freedom from major 30-day complications, and limited wound-related procedures were the features that most frequently prevented classification as a textbook outcome. The comparison of limb level variables between textbook outcome and non-textbook outcome groups revealed that textbook outcome limbs more likely to present with lower Wi-Fi wound and ischemia stages and lower overall Wi-Fi clinical stage. Multivariate analysis identified that residents in assisted living facility, diabetes mellitus, and oral anticoagulation use were associated with significantly lower odds of achieving textbook outcome. In contrast, limbs which were classified as Wi-Fi clinical stage 1 demonstrated a more than twofold increased likelihood of achieving a textbook outcome. Kaplan-Meier analysis demonstrated significantly improved amputation-free survival in limbs achieving textbook outcome compared with those with non-textbook outcome. During the study period, there were 171 major amputations, with significantly lower rates observed in textbook outcome group at 6%, compared with 23% in non-textbook outcome group. Textbook outcome group patients were also exhibiting a significantly lower mortality rate. At 1 year, survival was 95% in a TO group compared with 82% in non-textbook outcome group. The survival curves here illustrate significant difference in amputation-free survival across the groups, with textbook outcome group exhibiting the most favorable outcomes. Pairwise comparisons revealed no significant difference between textbook outcome group and subgroup number 1, whereas textbook outcome demonstrated significantly better amputation-free survival compared with subgroup 2 and subgroup 3. So this article showed that despite excellent survival and limb salvage, textbook outcomes were achieved in less than 1/4 of patients undergoing revascularization for CLTI. Patients with Wi-Fi stage 1 had a greater than twofold odds of having a textbook outcome compared with all other Wi-Fi stages. Patients living in assisted living facility, patients with diabetes, or someone who was taking anticoagulation chronically were less likely to achieve a textbook outcome. Current performance metrics fail to capture the true procedural burden associated with revascularization. I do appreciate your attention, and I would leave the thing for discussion.
Dr. Kanzafro, thank you. That was a great presentation. And Dr. Pitcher, that was a great introduction into this whole thing. I'll tell you, I've read this paper a number of times. I continue to have some struggles trying to figure out a couple of things. So I love papers that show that patients that are healthier do better. That's always a good thing to document. So when I look at manuscripts like this, I like to go through it in a similar way to what I do if I'm reviewing it for a journal, right? So I kind of go through the pluses and minuses of both the objectives, the methods, results, and conclusions. So let me ask you first what you think about the initial premise of the paper, this textbook outcome concept. So a textbook outcome obviously has been defined a little bit in other areas, has not been really well defined in CLTI. You know, we had the picture of the yellow brick road on the introduction. This is sort of like the fairy tale outcome, right? Like the people that get limb salvage, no complications, et cetera, one procedure, nothing on their foot, and they're good. 24% in this cohort. So what do you think about that definition of a textbook outcome for CLTI?
Good evening. Thank you for your question. And Grayson, thank you very much for that introduction. That was hilarious, as well as that trip down amnesia lane, as well as to the JVS and Misty and everybody for the opportunity to represent our work here tonight. So the definition of textbook outcome, we derived this from an old paper from the University of Oregon back in the mid-90s that was trying to define what they called the perfect outcome after infrainguinal bypass. And what they found was they used a lot of the similar metrics as us, minus the reinterventions for endovascular procedures. But what they found was their perfect outcome occurred in 14% of patients. And so what I try to do is recapitulate that vis-a-vis their historical cohort to see if, hey, have we made any progress in the last 30 years? We've had all these newfangled devices. We've got multidisciplinary limb salvage teams. We've got better imaging. In theory, we have better penetrance of optimal medical therapy. We should be doing better, right? So I wanted to see if we actually made any progress with regards to this ideal outcome metric. And then the second thing also relative to whether or not this is really what we want to be studying, I think this is important to study because I do think many of our patients lack the sophistication that perhaps many of the people that are in the business have. And they do have kind of an idealized view of what their outcome is going to be like afterwards. I think they think that, well, somebody sticks my groin and it's this nice cozy procedure. I don't even need a big incision. They're just going to balloon it and then I'm going to be completely fine. This big, huge wound on my foot is going to heal magically. And I think it's important to communicate to patients that that's not actually the case. There's a lot more work that's entailed, and it's important to describe that for them so they can make better informed decisions. Finally, I think having this type of outcome metric is important when you're trying to realistically compare different cohorts, as well as quality metrics between individual providers, between institutions, and between clinical trials. It's one thing to say, for instance, that we have a primary patency of 80% and a limb salvage rate of 85 and amputation-free survival of 9%. You should buy my new stent. Well, hold on. Let's look at your patients a little bit closer, and let's look at your outcomes a little bit closer, and let's really get in the weeds and see if this really is better for patients. So for those reasons, I think that we do, yes, need a new outcome metric. The prior outcome metrics that have been in existence are great, and I'm not denigrating them in any way. I think we all stand on the shoulders of giants, right? All the work that was done prior to us has been phenomenal and has helped push the care for our patients to a new level. But at this point, like I think if we're going to make any iterative changes and marginal differences for our patients and the population as a whole, I think we need to start looking at some of the other things like a textbook outcome.
Yeah, and that's a fantastic point. And it's a really important thing to bring up, obviously, as you bring up, Dr. Chung, with patients in clinic. You know, this intervention that they undergo that may be the bright, shiny new thing may not be the only thing, right? Like they're going to be stuck with you for years, potentially trying to get their leg healed. And not everybody's going to get to the point of just having a healed foot within 6 months. There's going to be a lot more that goes into it.
Yeah.
one question in the results that I had with anticoagulation. So with anticoagulation, oral anticoagulation, the odds ratio of a textbook outcome was 0.5. And I found that interesting. We published that in 2004, actually, when I was a fellow, looking at outcomes after redo bypass, showing that anticoagulation was associated with worse outcomes. I think the explanation is probably simple, but why do you think that is?
My personal bias is that it's a proxy for the conglomeration of comorbidities that result in the patient being on anticoagulation in the first place. There were some people that questioned that odds ratio, saying, well, this actually flies in the face of some other Voyager trials and some other anticoagulation trials that have recently been published. Why do you think there's a difference? And so I think the application of this, the variable is a little bit different with respect to those trials. Those trials looked at that as an intervention while controlling for all the other comorbidities, whereas this is looking at it somewhat differently, right? And so I think that's probably what's going on there. It's more of a proxy for something that we haven't defined a little bit more discreetly.
Yeah, I agree. It's more likely non-scientific selection of people being selected for anticoagulation, right? You're taking people that have the higher risk interventions and you're giving them anticoagulation, and therefore their interventions are not as good just because of their anatomy, not because of the anticoagulation itself.
Correct.
Anil has a question on here. Although this is related to the Wi-Fi score, was there a difference between those with gangrene, ulcers, or rest pain? It looks like there was no difference for the endo versus the open revascularizations. Any commentary on Dr. Kingerhani's comment?
Yeah, so no difference between the open versus endo. I agree with that. And we studied that pretty closely. Ran that several times in light of the best CLI and the basal studies that have recently been published. With regards to rest pain in and of itself versus gangrene, gangrene is a very wide spectrum. Rest pain, what we're finding more and more, behaves a little bit more like minor gangrene. And so rest pain and gangrene, if you look at just that frank comparison, it doesn't actually work very well. And I think that's why there's the genius behind the Wi-Fi classification, right? That's why we have it, to get a little bit more granular and determine which patients really benefit from a revascularization versus those that do not. And there's been multiple publications from our group and as well as others that are finding that the division between rest pain and gangrene, it's not as dichotomous as previously thought by the Rutherford classification. And in fact, the Wi-Fi classification is actually a little bit better. Rest pain in our cohort acted more like those patients with minor tissue gangrene. So your wound zeros and ones were more similar. Sometimes your wound twos. But when you got to wounds 3 and 4, this is where you start to see the larger differences between the cohorts.
In looking at table 3, the Wi-Fi stage 3 ischemia patients actually had a surprisingly high number of patients that had a textbook outcome. Do you think that's because those were primarily patients with rest pain, or do you think that's because those were patients with tissue loss? I mean, it seems to me that it's probably rest pain was probably the primary issue there.
Could be. I'm not exactly sure. We found a similar association in other publications. We had a publication several years back where we compiled all the Wi-Fi data from 10 different centers and tried to find which component of Wi-Fi was most predictive of a benefit from revascularization. So it's sort of similar to this paper. And what we're finding there was those that had like a very high ischemia were definitely in the category where they would benefit from revascularization. And I think we're seeing the same message here. For those that have severe ischemia scores, it doesn't necessarily mean that, wow, these are the worst patients. It means that these have the most potential for improvement with revascularization. And so, yes, there's probably a bunch of rest pain only patients as well, but there's also those that have ischemia as the main driver of their wound and their limb threat. right? So that's why I think that those with high ischemia scores tend to do better with the revascularization and a higher incidence of textbook outcome. If that makes sense.
No, it does make a ton of sense.
Yeah.
Other questions from the group. Looks like a question from Dr. Sen. Were there any data on utilization of vein bypass for CLTI only if a year after the best intervention?
I guess I'm not quite understanding that question. We did do a comparison between endo and infrainguinal bypass as well as vein bypass. We couldn't find any difference with regards to that particular revascularization strategy and textbook outcome, if that's what your question is.
Any other questions from the group out there?
Well, I guess hearing crickets, I guess, thank you everybody again for the opportunity again to represent our work. We really like this paper. Everybody that worked on it, Junaid did a great job, and everybody here at Baylor was, our division was really proud of this particular one. So thank you again for the opportunity.
It's very well done. It's a really good example of things to tell our patients, right? To let them know, they may have this idealized outcome in their head of what's going to happen after their intervention, but the reality may not match their perception of what might happen.
Yeah, and that's really what I wanted to do. I wanted to pull back the curtains a little bit for patients, and hopefully, maybe if they know what they're getting into a little bit more, maybe they can make more precise, personalized, better decisions and better match what their expectations are versus what the expected outcomes are going to be.
Well, thank you, everyone. Thanks for joining. I believe the dates are already posted. I think it's September 10th for the next Journal Club. So please attend. Please ask your trainees, colleagues, and friends to attend too. Thanks to all the authors, the presenters, the JVS for their time. Again, the Young Surgeon section attendees, if there's anybody else who would like to host, please reach out to us. And have a good evening, everyone.
Excellent. Thank you.